as well?
Yes, sir. Jaideep sir has joined. Natarajan sir will be joining in 5 minutes, he just told me.
Okay, all right. Let me.
Hello.
Okay.
Hi. Hi,
Hi,
Dr.
Judith.
Hudson.
How are
Good
you
Hi,
morning.
doing?
Jaideep sir.
I'm good. I'm good.
Yes, sir. Jaideep sir has joined.
Okay. I
Dr.
will.
Pooja from Amrita Institute has also joined, sir.
Okay. I'll give you the link from YouTube as well.
Yes, sir.
I think I will put here in the chat. This is the link for YouTube. And yesterday I was watching the Retina Society meeting. That was great. You know, everything now comes virtual.
Right.
And that's the way it's going. But I think it's a good idea. And did you guys watch yesterday the Retina Society meeting?
No,
It was
sir, I did not
supposed to
watch it.
be.
I couldn't join, sir. I was at the hospital yesterday.
Ah, okay. I I was supposed to go to the Retina Society meeting in New York, but
Oh,
it was not possible due to coronavirus. So
right.
I couldn't join there. Nobody actually, and they canceled, as they canceled so many meetings around the world, and we have the Brazilian Congress of Ophthalmology next April. I hope it's gonna work by that time, but people cannot tell everything for sure as of yet. So we keep hoping for good news and praying for better news, and that we're gonna be free from this situation, no? And okay, everything is okay,
Let's
all
hope
set.
so. By next year, we can have meetings.
Yeah, maybe we could
Probably
meet each
by March,
other.
April.
Yeah, that's it. It's gonna take a while, but we hope that's gonna happen. So I'm just sharing the link with somebody else, and we'll just take 2 more minutes for people to join in, and Natarajan as well. And actually, I was going to tell you today about more advanced techniques in vitreoretinal surgery, things that we probably gain in time from experience and time doing the surgery and these things. And I would like to share, because this is interesting that we share and we discuss cases, we talk to each other, and that's, for me, it's of utmost importance that we discuss, and it's good to know whatever you do in your services, and whatever we could do to improve. So many, I was listening to Retina Society yesterday, and still things to be performed that are not performed from everybody. For macular hole, for long-standing macular hole, for example, in those macular holes that don't close, you gotta do, autologous ILM, or RPE graft, and things people somehow do and perform. I already made some. fancy surgeries, but you never know whether you're gonna get 100% sure. Oh, this is gonna work, and you have the PVR as well, that always come with this potential of creating some problems. But still, we hope these techniques, these new techniques, and these things are going to be just right within time. And that's a matter of time. So I will share. I was preparing a video yesterday for the Cordoba meeting. The Cordoba meeting is a meeting here in South America. It's going to be totally online. So we record the videos, and after we recorded the videos, we send them the videos off to this meeting, and so they're going to be putting these videos online by the time of the event, and it's going to be just a cool event, and I'll share with you the links later on for you to participate. And they have this meeting on actually it's a contest. If you play any sport, like me, I did wrestling, so I could send a video on wrestling because I'm ophthalmologist, so I'll be taking part in the Olympic Games. That's good because
That's very interesting.
yeah, I'll share with you later. And I
Great.
was preparing the, and then I was preparing a video for us to
It's
see.
the Retina Olympics, is it?
What is that?
It's the Retina Olympics.
Yeah, Retina Olympics, yeah. Yeah, it's nice. So I
Great.
got a video from wrestling that I took part in Mexico, the Pan American tournament years ago, and I chose this video. I think it's gonna work somehow, you know. But you know, it's a dream for us to be in the Olympics, and I was athlete in wrestling for so many years, but it was not possible to participate because I had to study a lot for ophthalmology residency and these things, and but I still play somehow. I play judo now, but I'm not into competitions because I got a little older, but I'm still in shape. It's good. So
That's great. That's fantastic.
yeah. Do you practice any sport, Jaydeep?
Well, not anymore. So I used to play hockey while I was in college and in school.
Yeah, it is interesting because of weather. Maybe in some
But
season.
yeah, once
you
you
could,
go into medicine, then it's very difficult to continue.
yeah, I know. Yeah, I know. Not that easy.
Hello,
So,
Dr. Hudson.
what is that?
Asta here.
Hi, Asta. How are you doing?
I'm great, sir. How are you?
I'm fine. We are fine here, and it's good to be with you. And I have to present you. They are online here: Carlos Alberto, Carlos Henrique, Jessica Fassbender. Three of our 5 retinal fellows. Nicole is on vacation,
Okay, great. Hello, everyone.
and Jessica presented
Yeah, hi everyone.
last week. And Rodrigo Morato is there too.
Yes.
And Rodrigo is from the Clinical Retinal Fellowship. And Professor Natarajan just got in. Hi, how are you, Natarajan?
How are you?
I'm fine. I'm fine.
Sorry,
Francine was very happy to participate into that next event. She was calling
Yes.
me. She was
On-
excited. Yeah, this is good.
Yeah, day after tomorrow.
Yeah.
I just sent you the invitation in the group.
Yeah, I saw it. And she was very happy calling me and asking how would you perform this and that. I said, no, Natarajan is the guy. So don't worry about it.
Good.
So I was telling the residents and fellows about, you know, after a while, you get to a level that you may do different techniques in vitreoretinal surgery. So that's why I elected today for us to discuss some points into vitreoretinal surgery. And so I will share with you first a video where we have involved the giant retinal tear, we have involved PVR, we have retinotomies, retinectomies, we have PFC, we have lasers, and how should we go more or less and do more or less retinotomy, this and that. So I will share the video. This is a cool video. And so we discuss the video as well. I actually will present this video in Oftalmo Cordoba, Argentina. It's gonna be October. Was telling them, and so I will just put it right here. Last time I was trying to share my screen and I was not sharing. Can you see my screen now? The
Yes,
inverted.
yes, sir.
Yeah.
Yes.
Okay, so let me
Yes,
enlarge
sir.
it. I will enlarge it and that's the eye bank foundation, and the surgery is posterior retinotomy for giant retinal tear with fixed folds, PVR. And the thing is here, what you do, and what if you have this patient with a lens still there and clear lens, and should you go ahead and do lensectomy or phacoemulsification and intraocular lens for every patient? And it's possible to go too far in the periphery without hitting the lens. So it is. So you have this here, this very large retinal tear, but you see that the patient had a trauma in the past. So you see the giant retinal tear, but still you see up above, you see PVR, and you see subretinal fluid, you see macula alpha, superior retinal detachment as well. Only a bit of the retina inferiorly is attached. So cool images, and you see on the right side the fixed folds. So how could you possibly flatten these fixed folds? And it's not possible. So I started with very peripheral relaxing retinotomy. By this point here, and I will point out for you, some would probably start working on the fixed fold itself. I tried doing that, but it wouldn't open anyways. So that's why in this case, in this specific case, I had to go and do the relaxing retinotomy. And now I am actually folding the retina to work in the posterior subretinal space. And in this way, I get rid of RPE cells and trying to avoid proliferative vitreoretinopathy. So after doing the core vitrectomy, I did the relaxing retinotomy superiorly, and now I'm working in the posterior retina there, subretinal space. So Natarajan, I want to point out this detail here. You see the edges of the retina, of the giant retinal tear, they are folded. You see? You have cystic changes. You have the folded retina at the very periphery, as you see. Here, you see the retina is folded. Can you see my arrow?
Yes. Yes.
So you see the retina is folded here. You have cystic changes. And so how could you get rid of these things? And unless you could probably continue the retinotomy with the opening of the large retinal tear, which is already there. So how, Jaydeep, would you do the same? Or would you do different? Would you go straight on the retinal star and try opening the retinal
No,
star there?
I would first, I'll first try to open the star by probably taking a pick or some instrument so that I can lift the membrane at the center of the star, and they use a forceps to remove those membranes and try to flatten the star. That's what I would try first. I mean, at least to some extent. I will try to release the, if I can't feel the entire membrane, I will at least try to release the traction which is at the center of the fold. And then if not possible, it's not coming out, then I might leave it and then try to flatten the retina with PFCL and check if it is flattening all right. If not, then then the last reserve would be a relaxing retinectomy.
Yeah, actually, I tried doing that beforehand. You know, before carrying on with the retinotomy, I approached the star, and the only traction we had was the vitreous itself. So I removed the vitreous, and I tried getting anything out of the retinal star over there, the fixed folds, but there was nothing. It was internal. That's the point.
Maybe it was intrinsic contracture rather than a membrane causing the fold.
Intrinsic. That was intrinsic. Right. So the tractions were from inside the retina in, just pulling it and shortening it. This was interesting. So I continue here with the posterior subretinal vitrectomy. And guess what I'm going to do there? You see a small, tiny bleeding vessel over there?
Yeah.
This small, tiny blood vessel there, just bled due to our approach here, but it was so small that it didn't cause any problem to the surgery, no hazy media. And so at this point, this is very interesting because this is a unique surgery. We don't do that for all patients, but we had to fold the retina over, and here I'm creating a retinotomy from the posterior side. So I folded the retina, and I did where the star was, where the traction was, the posterior retinotomy at that place. You see, Natarajan, this is interesting. I did that to relieve that space, to relieve that area from the traction that was caused in the retinal detachment and giant retinal tear itself. So there, see, I'm opening a hole.
Yes.
Exactly, I'm removing the fixed folds at the core of the fixed folds posteriorly. And so what did I do afterwards? I unfolded the retina to the anatomic position, and you see there was a star, there was traction, but still I had to separate the retina, the healthy retina from the right side, from the unhealthy retina from the left side. So what did I do? I couldn't only put PFC there, because if I inserted perfluorocarbon liquid there, and then this perfluorocarbon liquid would go subretinal, and so the retina wouldn't attach. So I did this radial retinotomy from posterior towards anterior, as you see. In this way, I separated the retina, and I isolated the retinal star in the middle. And at this point, what's going to happen? I will insert perfluorocarbon liquid, and you see how the retina flattens. And if you look up above, you are going to see a triangle there. And you see the triangle on the right, and you see the retinotomy, the round retinotomy on the left. You know, it didn't hit the vessel over there, otherwise could probably cause some bleeding. And interesting here, now that I have the retina flat, and of course I cannot flatten everything because you see in between the radioretinotomy that I did to separate the fixed fold and the hole over here at the core of the fixed fold. And you see the choroid over here, and you see the retina flattened, but you see this kind of stalk at this area. But if I had to remove everything over here, I could probably increase the likelihood of having the PVR. So that's why I did I limited to this area, and I did endo laser around the areas that the retina, where the retina was flattened. As you see here, the round retinotomy. Now I'm gonna go towards the radioretinotomy. Actually, the radioretinotomy separated this healthy on the right side, the healthy retina from the damaged retina on the left. So I did 2 rows.
So are you doing continuous mode laser or?
Yeah,
He's doing a laser painting, right?
Yeah.
Like continuous mode.
It's
my
continuous
lasers,
mode.
it's almost continuous, but my settings in the constellation are 500, 200, and 100, meaning 500 is the power, uh, uh, 200 or 300 is the duration, and 100 is interval. So it's very fast, but it's not continuous. That's why you see the points over there. But I try to do a line, you know, a line. It's like drawing a line around the areas. So that's going to give you the nice healing, nice scar, like a line, a black line in the future after the laser resolves. And you see the areas that I did laser around are flattened. You see, they are flattened, and you don't see, even this area here, this fold, you know, the laser took it, so the retina superiorly is attached. So, Natarajan, what do you think about it?
I think you managed it very well, because this is like I also have some patients like this where you do do the retinotomy on a really tailor made, not as a just cut everything in the peripheral part. I think it's really preserving some area of retina and also exposing less of RP, which is good.
Yeah, I try first to go, and as we do for all patients, we remove the vitreous, and then we try to get rid of any tractions. But sometimes, you know, this was a traumatic a giant retinal tear, and the patient took too long to show up, and they wanna have the operation, but you may not get the operation for the right time. So that's why we have to be more invasive, you know. So going back to that part of the surgery, so we did the posterior retinotomy over there, and then we unfolded the retina. After unfolding the retina, you see I'll do the radial retinotomy. So the radial retinotomy is going to separate the healthy retina on the right from the star-like areas. And as soon as you do retinotomy, peripheral retinotomy, the retina is shortened, so it gets back to the position it should be without causing traction. So with the PFO, you could flatten all areas, but now you have to hold the areas the retina is still. So the laser was the next step, and after this step, I will forward a little bit, and we have the next step here. Whatever we did was we decided to do more laser 360 degrees. Sometimes I like doing laser, but only one line wherever the retina is not detached, so that in this way you avoid any tractions from the lizard in the area. So avoiding the traction from one side to the other side. And we use the wide angle. So I'm doing here the more laser around and just to hold it firm. And the good decisions now was to do a direct exchange. You see the silicone oil coming in, and this direct exchange.
What kind of silicone oils, teacher?
I like doing that. What is that?
What kind of silicone oil? 500?
Yeah, yeah. This is 1,000. 1,000. Thanks for asking. This is 1,000 silicone oil, and I like. You see, the lens is pretty clear. You don't have any lens touch. And Natarajan, we are going to be talking on the trauma course from Hugo Ocampo, and my theme was chosen to talk about, avoiding touching the lens and being very careful with the lens when you don't need to remove it. Because, you have lots of things to do in this case, and you could actually, if you are trying to do very peripheral retinotomies, you could remove the lens as well, but then that could probably and possibly increase the possibility of PVR, and so that's why I prefer not to remove the lens unless it's necessary, and by any ways you go to peripheral and then you had to remove the lens because you've touched the lens. And what I'm gonna tell in that event, in the future event, is that it's possible to spare the lens without touching it unless you need it. And you see, that's a great example. We go very peripheral and the lens is there, pretty clear. And the reason I want to discuss this with you now, and I would like the opinion from JD and Professor Natarajan as well. I like doing, we have to our service, we have the Constellation and the Stellaris. They both have automated injections, but I rarely use the automated injections because oftentimes when I press on the pedal, I got too many bubbles around, and the silicone coming in. Even though you go slow, sometimes you get these bubbles around. So I do this manual. So I have the silicone oil on the side in a special cast like that, and you rotate the device, and then the silicone goes very, very slow inside the eye, and at the same time you remove the perfluorocarbon liquid. And Carlos, both Carlos and Jessica, they know Rodrigo as well. He's been following me for some time, even though he's a clinical fellow, but sometimes he shows up in the OR, and I insist that I has to go to the OR as well. And so you know that I do that way. And so by doing that, you see, I use a wide angle lens, you see the silicone oil coming inside. You see everything all flat there. So I did not have the retina raised. And so I put the backflush cannula after I removed the silicone oil. This is the thing. I started removing the perfluorocarbon liquid from the holes area, so I don't have here any more perfluorocarbon liquid. So the perfluorocarbon liquid is only here in the middle, so there is no way perfluorocarbon liquid will go under the retina. What do you think about it, Professor Natarajan?
Yes, I think I agree. I keep the PFCL up to the brim of the retinal tear, and I actually use the viscous fluid injector and then do a PFCL oil direct exchange, which is always good because you won't get any slippage of retina. So rarely I do a PFCL air exchange and air oil exchange.
Yes, I like doing that because if you go straight here and start everything from the middle, the PFC comes and keeps going and could go inside the main retinotomies. As you see here, it already passed 80%, 90%, and I see everything is flat. You see here, I guess you can see the line here of the perfluorocarbon liquid.
Yes, yes.
So it's coming over here, just at the edges of the holes. That's the pathway. So if I start here, and the PFC is out there, so it could well come inside. So since I started here and I see nothing's coming inside, it's coming into my backflush cannula as a single bubble, and it's coming and flowing well, and the retina is flattened. So now I move my drainage, my passive backflush drainage here with the backflush cannula. I move it to the center. So what do you think about that, JDIP?
Well, sir, you're saying that you start PFCL oil exchange from the peripheral part of the PFCL bubble. You put your aspiration, the needle there, and then you aspirate till it reaches the edge of the brakes.
Yes.
And then once it's past the edge of the brakes, then you bring it to the center.
Yeah, that's the idea. Remember, Carlos, we're doing that?
Yeah, so I think that's a good idea, because as you said, some PFCL can go under the retina. So what I do is I remove the fluid anteriorly first and let the oil reach the pupillary plane, and then I go between the oil, which is superior, and the PFCL down. In between there is a meniscus of fluid, so that is in the periphery. So I remove that, and as you said, I come to the edge of the retinectomy or retinotomy, and once I reach there, I aspirate the fluid. Sometimes there is some fluid under the retina, so I keep the flute needle at the edge of the retinotomy or the break and let the fluid from under the retina get out, and then I come to the center.
Great idea, and I'll tell you, you pointed out a very good question. And
because otherwise that fluid can streep under the retina later.
Yeah, this is very good, but you have to think, this case, the patient is phakic. So think about it. You know, I like when I insert perfluorocarbon liquid right before doing the direct exchange, that I call this direct exchange. So I exchange PFO for silicone oil. When I insert the perfluorocarbon liquid, the perfluorocarbon liquid should go up to the ora serrata. Because if it goes that high, you won't have much fluid, BSS. So that's a good idea to do, because if you have too much of BSS and you have to go too peripheral to remove it, you might touch the lens. That's the point.
Yeah.
And so I agree with you. Yes. I agree with you, and I do exactly the same. But because this, especially this one, I do for all, but especially this case where you have these
phakic patients, correct.
Phakic patient, I go and I insert perfluorocarbon liquid up to the ora serrata, and then maybe a little more, not much, maybe a little more, and then I start injecting the silicone oil. So by the time the silicone oil is coming in, I go to with the cannula, I go as peripheral as I can without touching the lens. And how can I not touch the lens if I have to go too peripheral?
You can go on the same side as your aspiration needle. Don't cross the lens. Go to the same side. Suppose you're in the right hand, you have the aspiration needle. You go towards the right side periphery.
Yeah,
rather than going across.
This is a good idea. So you start, but what if the hole, like in this case, is on the other side?
Other side. So maybe
you have to cross.
You can change your hand. You have to cross or use the left hand or something.
Yeah, good ideas. But in this case, I will tell you, I did not change. I did not switch, my hands, and I just did it with the same hand. But how? And this is a subject from the class, from the lecture I will be giving on how to spare the lens.
So you said that in phakic eyes, you need to put PFCL right up to the as much as possible, as you said, fill the globe with
Yes, yeah.
PFCL as much as possible so that there is very less VSS inside.
Yeah, this is the first idea, so that you don't have too much BSS or fluid left in
Right.
between the silicone oil and the perfluorocarbon. But then I'm gonna tell you now how can I approach and I go straight to this BSS in between the two things, silicone oil and the perfluorocarbon without hitting the lens. So if I'm going and our fellows know that, and we teach them how you rotate the eye during the surgery. If I do the surgery like that, and the eye is, just stuck without any movement, of course, if you cross, you're gonna hit the lens right away. So if you are temporal of your nasal, if you want to go temporal, you have to put the eye in the other position in the nasal. You have to move, they rotate the eye nasal. If I want to go temporal, imagine this. I want to go, in this case, I want to go nasal superior. So I rotate the eye temporal, inferior. By doing that movement, the backflash cannula pass below the lens without touching it. If I do that way, it will touch. But if I rotate the eye like that, and I have my supranasal part over there that I want to drain, and my backflash cannula, you go past it without touching the lens. This is a matter of moving the eye. It's not easy to do that, but we train that a lot. And actually, these ideas, of course, at the beginning, you have to switch the hands and things. And if you want to have the eye stop it there without moving. But if you move the eye, you can actually do that without touching the lens. And very great ideas, as you said, in this way, switching the hands and going periphery. You don't have too much BSS there because you already put too much, not the right amount of perfluorocarbon liquid. But if you don't want to touch the lens, that's the way to go. And
Yes,
at the
sir.
end of the case, everything is clear. So have you heard about it,
Yes, sir.
this technique?
Yes, sir. I use this. I use this technique only. I rotate the globe as you described in the direction in which I want to work. So if I want to work in nasal quadrant, I will rotate the eye in that direction, and so that minimizes the chance of hitting the lens. So the angle created by rotating the globe will, the instrument shaft will pass by the equator of the lens and not at the pole, posterior pole. So the chance of hitting the lens is minimized. Of course,
Yeah,
it requires
that's
practice,
yeah.
and
And
you need to
another
move
thing.
the microscope also along with it. The microscope XY also has to be moved so that you are in focus. So that
Yes,
movement
yes,
of
you
the
are in
globe and the
focus.
microscope has to be together. Otherwise, it will be very difficult.
Yeah, yeah, you have to be always in focus. And another thing, depending on the lens you use, if you have a very wide angle lens, like the SSV from Vogue, that has those foot plates, and you actually can see so peripheral, you become happy. Also, this lens is so good because I see so peripheral. If you go too peripheral, you touch the lens. So I'm very
Having a very
sometimes.
wide angle view is very risky in a phakic eye, actually.
Yeah, yeah,
Sometimes you can see up to the aura and you feel you can reach there because you can see it, and that is when you go across the lens and hit the lens. So you need to be careful. Even if you can see the aura, try not to get tempted to reach there in phakic eyes.
oh yeah. Oh, I wanna ask. We have a friend here from Argentina, Augustine. Augustine is a fellow in Argentina, in Cordoba, from Dr. Tiziano. Augustine, good morning. And
Hello.
Augustine,
Hi, Augustine.
was helping me yesterday to record the video for the event in Argentina. And if Agustin, I don't know whether he's listening or his mic is off, but he's a retinal fellow. If he would like to comment on that, are you listening, Agustin? I'm very happy that he accepted our invitation to participate. And Rodrigo, do you want to comment on that? Rodrigo Morato.
Hi, doctor. No, very well explained.
Thank you. And Jessica, are you around? And yeah, this we are used to do this step. So I'll go on with the surgery. It's almost we are almost done here. So doing the direct exchange, you get the PFC up to the end. You don't leave any PFC droplets. The lens gets clear all time, and as you see here, the passive way, it's the best way to remove the fluorocarbon liquid. I don't aspirate actively. I think you do the same. I like doing the direct exchange because in this way the media does not get hazy. You see the whole thing up to the end of the surgery. So you remove the last droplet. See there? The last droplet we remove. The retina is attached. And the thing is, how many of you perform air fluid exchange before doing all this? Because actually, in this case, you see the retinal detachment, the PVR, the superior, and all problems. So I wouldn't dare doing the air fluid exchange, even though I could do the air fluid exchange very slow to keep the retina attached. But my experience is that when you do the air fluid exchange, in those cases where you have some tractions, you actually have the retina more mobile and then dislodge your retinotomies over there to the wrong place. And sometimes you rotate the retina. So I don't go to air fluid exchange before. In those cases, I like doing direct exchange. What about you, Aishwara? Did you like it? And do you have any idea of what would you do when you do more vitrectomies? Would you like doing this direct exchange, or would like to go past the air first and then do the silicone oil? Or maybe JDip. Asta
yes,
is
Dr.
there?
Hudson. Yes. Dr. Asta can say maybe.
Yeah, Dr. Asta.
Yeah, no, I think in such giant retinal tears, I think it's always better to do the direct PFCL oil exchange because there's a high chance of slippage with even if we do a very slow exchange, the slippage is always a problem. So it's always better, I think, especially in cases of, in a small tear in a HST, I usually perform my air fluid and followed by oil. But in such GRTs, direct exchange is what I prefer.
Yeah. I think it's better. I do that, since I started vitrectomy, and I saw that it works better. And what if you, even though you do that, what you have this retina rotation, and it's very interesting. We have too many things to go on and perform surgeries, but if you have some folding or some rotation of the retina, I like using the tip of the endo laser, which is round at the very periphery, in the very tip. And actually, I use that to unfold those retina folds that could come after the exchange. If you see up above the retina folded, you go with the tip of the endo laser and flatten the retina under silicone oil, and it works pretty well. And another thing that at the end of the case, I tell all patients and explain and I show them, you have to do face positioning and face down. Otherwise, if you don't do that, in this case, probably would work anyways because the retinotomies and the PVRs and things we worked and we did everything was superior. So if the patient was staying with the heads up, maybe the silicone will go there and tamponade the holes and breaks anyways. But I stress them and emphasize them that you have to keep your face down all the time. Otherwise, the retina could not be attached. And for these cases that I do too much with the retina periphery and we do retinotomies and I offer the patient in the postoperative period. I usually give them corticoids so that we decrease the possibility of PVR. There is not a hard and fast rule for PVRs, but we do that for our patients, and we still have some in those cases, and the PVR that could happen, but still we have to work trying to do the best for the patient. And if you do less surgery, that could work. But if you do more surgery, that could work more. So depending on the case, you cannot go in between. You have to do more or less, but you have to do what is necessary for the patient. And it is an interesting case. I have another case, but it could possibly take too long if we go showing the next
Dr.
case.
Hudson, I just wanted to ask one question. You don't do any cautery to the edges of the retinotomy, or before you do retinectomy, you don't do any cauterization to prevent hemorrhage?
Yeah, I do that. In this case, I was showing at the beginning of the case, we had this tiny hemorrhage, but the vessel was almost closed. So it didn't cause any problem. But sometimes if you have some bleeding during the surgery, I like to increase the bottle's height. I put the pressure up to maybe 50 by the time you are doing retinotomy. And then I go back to 35, 30, and I have the cautery, especially for diabetic patients I use, and I still start the proliferative diabetic retinopathy retinal detachment patient. I start with the cautery in the hand, so anytime you have the hemorrhages, and I use it, but sometimes the perfluorocarbon liquid that presses the vessels and could halt the bleeding as well. So in this case for retinotomy, I did not use it because it was not necessary. Everything was quite whitish over there. So we didn't need to do the cautery and worked well. But if you have more bleedings, of course, and if you the secret, I will tell you, I do that first always, and I learned from my professor Marcos Avila here in my first retinal fellowship here in Goiânia, Brazil, that if you go very peripheral to do the retinotomy, you don't get any vessels. So you could do a perfect retinotomy and dry retinotomy without any bleeding. But if you go a little posterior and you get the end of the vessels, then you get some bleeding. So then if you want to go there to do more retinotomy, because if you are doing just a peripheral retinotomy to relieve the retina, that's okay. But if you are going towards a vessel, then it's better off using the cautery. And then I agree with you. You always use the cautery, Natarajan?
Because sometimes
you, Dr. Natarajan, you always use the cautery for your patients when you doing retinotomies?
No, but I think if it is going to go through a blood vessel, then I do it. or I use the diathermy itself. I remember when we were working with Jovanovich in '93, they were even trying to get something like a microwave without touching to do a retinectomy. But anyhow, Dr. Jovanovich was not interested in making a new instrument. He said, one more toy, my nurse doesn't like it. So that diathermy was used. I've actually put a reference in the notes. You can probably share that screen, Hudson. I actually developed a curved vitreous cutter for a phakic vitrectomy, for doing a
Oh
basic
yeah,
incision or even a retinectomy. So that I published in the Indian Journal of Ophthalmology at that time.
yeah.
You,
That's
you
very
can
good.
open that.
Yeah, I think that case was cool. It was an interesting case, and this
Dr. Gatarahan,
the,
what your experience about the silicone belt around the road before to start the vitrectomy for this case?
the uh, the experience of what?
A silicone belt, faixa de silicone, como é que falaria?
Ah, this silicone band. The okay, okay. For this case, so Natarajan,
Yes.
Carlos is asking, what's our experience, and we discussed that. Actually we saw the discussions yesterday from the Retina Society, whether you should go buccal vitrectomy or only vitrectomy. He's talking about Carlos camera is talking about the putting the band around the eye, the 240 band. That would
But if
make
it is
any difference?
yeah, if it is a giant tear, usually I don't use the belt buckle. But if it's only a PVR with a peripheral brakes or one or two brakes, then I actually like to put a band. Actually, when I do a vitrectomy, I tighten more so that I can do a basic excisions. I don't like to do lensectomy as a primary procedure or even a phaco with IOL. So whenever the patient is even 50 plus with a clear lens, I like to preserve the lens. And I probably like to, if the cataract comes post vitrectomy, I would like to do a phaco IOL with an oil removal so that you've got a good visual rehabilitation. But in case, I mean, that's where I think I made this a curved cutter. And belt buckle, is, I call it belt buckle, where, or you put a 240 encircling band, and which will help to bring the periphery in view using the wide angle, and you can go exchanging the retractor from the upper nasal and upper temporal so that you don't go exactly diagonally opposite so that you don't touch the lens. Because otherwise, by enthusiastically going to the periphery, you will touch the lens. So you have to be aware of that the eye is like this, and then when you're going to do the vitrectomy, putting the light diaphragm, don't go to the opposite end. You do only the basic excision on that part, and then again exchange the hand. So you can even remove the infusion line, put it on the upper temporal, and go through the lower temporal, and sitting in the same posture or even turning the table. The idea is to preserve the lens. Sometimes people may wonder, why not you do a phaco, and so I think natural lens is definitely something which you whatever you do with the IOL, I think the patient can lose the accommodation. So I think in case you can preserve the lens, and if the post vitrectomy the lens becomes cataractous, and obviously we can do a phaco IOL and oil removal, or even re-injecting oil if you want to change from 1,000 to 5,000 because of the recurrent PVR.
Yeah, I agree with you. And for the band, my comment would be in this case that we had to do too much retinotomy at the periphery, so the band wouldn't work much. But sometimes, in some cases, I like the band, so I created support. This you have the retina here, and you have the band. It makes like 90 degrees, almost 90 degrees. It's like a wall, so you don't have the retina, the free retina hanging there. And so if you have a band, a wall pressing and doing some some barrier, that would be better. That if you have not this case, could probably apply for you know, for this 240 band or any other band, but because he had too much PVR and the giant retinal tear, like the retina was already detached, so I decided not to do, and that wouldn't be wrong to do the band. And good questions, Carlos. Very good questions.
Thank you.
So anybody else would like to comment on these cases, these different approaches? You know, it takes a while.
Dr. Hudson, this posterior retinotomy which you did, what point you decided to do it? At the center of the fold, star fold?
So I decided to do the posterior retinotomy. In this case, I don't do that oftenly, but in this case, we had two things that made my decision taken. We had the star, the retina fold, and also the retina shortening. And so I tried to peel off any epiretinal tissue from the star and the retinal fold. It didn't come anything. So, and I saw the retina was anterior, it was shortened actually, very, very shortened. By the time I did retinotomy, you see the retina came from peripheral to mid-periphery. That meaning that it was traction over there. It had too much traction. And so I saw still by looking at the retina that you had this star, you had this PVR, local PVR star and the retina fold, and there were cystic changes all over the retina at that area. So because maybe the giant retinal tear was hanging there for quite a while, and so it started to fold itself. As you saw, the edges were folded, and also the retina became whitish, and we had intrinsical cystic changes. And so I folded the retina, and I decided to open that area. So when I unfolded the retina, so it was attaching easy, and of course, if some areas were not attached, we could probably have made more retinotomy, but I didn't want to perform too much retinotomy. And so that's why I decided to do that local removal of the star-like PVR and the fixed fold.
Right, sir. No, what I asked is, why did you have the posterior approach? Any particular reason for going from posterior approach?
Why? Because I think it was easier to go, because I was already doing subretinal work, subretinal vitrectomy. When I folded the retina and I went posteriorly, the retina would come, but not much. You see, the retina is folded. You do the retinotomy over there, the retina doesn't come as a whole. If the retina comes towards your cutter, and then it has limitations of movement. When you have the anatomic and normal position and do retinotomy over there, everything could come up. The retina and the healthy retina as well. So that's why, just a matter of, it was different approaches. And another thing is that anterior, in the normal, if you are facing the retina and you see vessels over there and you approach the retina from the normal side, from internal, from ILM area towards the RPE, I'm saying the normal way. If you have vessels there, you have the vessels actually there. And then you have to cauterize, use the cautery before doing the retinotomy, otherwise you have some bleeding. But then when you fold, you go from the RPE side, RPE side, I'm telling you, not, there's no RPE there, but the RPE side, the other part of the retina when it's folded. And if you do the retinotomy and you don't start getting the vessels from the superficial vessels, so you don't have bleeding. But in any of the cases, you might have to use the cautery as you pointed out at the beginning. So it's a matter of option, and I think the retina moves more if you go the normal way. But when you fold the retina and you do the retinotomy from posterior, you don't have much movement. So the retina is already folded. You just move that folded area. But if you have the whole retina
I
coming
understand.
towards you, that's that's could be a danger.
Right. Sir. And how did you choose the site of this radial retinotomy?
Yeah. You like using radioretinotomy?
No, no, like how did you choose the place where you would do the radial
Okay. Yes,
retinotomy in this case?
yeah, I was
What
showing.
made you decide that, or how should we
Okay,
decide
okay,
for
okay.
radial retinotomy?
As I was showing in the video, we have the star, we have the PVR here, we had the healthy retina over here, and in between we had this fold. I wanted to separate the star like the retina fold to the side, and then I would like to preserve the healthy retina on the other side. So by doing the radioretinotomy in between, I separated the two, like this. So
Okay.
there was no traction from this area to this area, because there was choroid in between. So that's why I decided, because when I saw this very large retina fold there, I saw, no, this cannot be here. But this still is causing traction in the healthy retina immediately besides it. So if I do a radioretinotomy in between, I will separate them both. So these won't cause traction on these. And so that's why it worked. And you see in the middle, there was still some retina fold over there, but I could do laser one side and the
Right.
other side, and then it stayed flat. The main thing here was to decrease the likelihood of traction. So that's why I decided to do the radioretinotomy as well, to decrease the
Right.
traction.
Right.
So the retina would sit flattened there, and the laser would be taken after PFC, and the laser would be taken, and still to keep things tight over there, I put PFC up to the Oro Serrata and did the exchange, as you said, removing BSS, and then things. The silicone oil was there, so everything was flattened. That was the reason. I think more maneuvers sometimes are necessary. Otherwise, you have a redetachment pretty soon.
Right. Right.
Okay, thank you. Anybody wants to
Thank
comment?
you.
Anything else, Natarajan? This was a very important, very interesting case we discussed. Very interesting case,
Okay.
and
The highlights is try to maintain the crystalline lens clear and do what is required and the right place at the right time. That means how do you do a radial retinotomy, and how do you assess the cystic retina, and also the curved giant tear at the edge, and how to use the least diathermy, and also to do a good endolaser so that you have a good choroidal reaction enough to hold the retina. I think excellent learnings from today.
thank you, thank you. We always learn with each other, and it's very good to share and to
Yes,
discuss. The main thing here, is Natarajan, is that we can share and discuss with each other our experiences.
yes,
And we are running and doing more in different techniques, and me and you, and you have a lot more experience from switching techniques from the past to the present, as you started with the biome and all those things, and we see that things have changed a lot.
yes,
When I finished my retina fellow in Canada, in Toronto, they were starting, that was 1998, I was finishing my fellowship over there. They were starting and doing more macular hole ILM pills, and you know, they were very shaky, and people were afraid of doing those things. And you know, things are just performed so better today. You know, we didn't have the 23, 5 or 7 gauges. We only worked. You remember those surgeries
Yes.
lasted almost 3 hours. Now we do surgery in 1 hour. So it's a lot better. So things got a lot better, a lot better.
We have started with the vitreous infusion suction cutter, which is a terrible thing. And I also done indirect vitrectomy, holding the indirect and then doing vitrectomy with the right hand.
With indirect?
Yeah.
Yeah, that's historical. That's good.
Yes.
Yeah. Do you have videos or papers on that?
No, that's what I'm looking. After doing all this, I'm trying to get it back. But that's from 1984 with my mentor, Dr. Badrinath. So even the giant tear, I used to lie down and we used to rotate the patient and lie down and do the fluid air exchange with the patient in prone position under
Yeah,
general
I
anesthesia.
think, you know, I was in 1997, I was doing my retinal fellowship in Toronto, and I was into the surgery with Dr. Lam. Dr. Lam. And he was telling me there is a guy in India that does the indirect vitrectomy. He's very good, but he does that exchange. I think by the end of the surgery, you did this the exchange or air fluid exchange. I think he mentioned you. You know, years ago, it was 1997, so you were already doing that. And Dr. Lam, Dr. Lam,
Yes, Wei Ching Lam.
Professor, yeah, that's interesting. Okay, so I thank everybody for participating, and this is a great discussion with Dr. Natarajan, residents and fellows, everybody.
Aishwarya has not answered today.
Yes, sir.
Thank you.
Yes, sir.
He was asking you something, but have you decided next week what are we doing?
Yes, sir. I had spoken with sir this morning.
Yes.
Sorry, when you asked earlier, my internet connection was not good. But then after that, you had already started talking about something else. So I didn't want to interrupt you. Yes, sir. This morning we talked about the topic. Sir was telling that next week we can have a class on diagnostics. So I'll present on OCT angio, sir. Since anyway I'm going to be reading it. You had asked me to read it also. So I'll read that up more thoroughly and present on OCT angio. And Dr. Pooja, she had to just leave now. She was there till now. Dr. Pooja will be presenting on FFA. She was asking if she can do that because it's a basic class.
Hudson, is it okay?
Yeah, of course. Yeah.
Okay.
I will tell the fellows we prepare OCT, the regular OCT, and Aishwarya would talk on OCTA. And
yes, sir. Sure.
That's great, you know. That's great, you know.
Jaideep
OCTA.
and Asta, okay?
Okay, that's fine.
Yes, sir.
Yes, sir.
No problem. Sure, that'll be nice.
Right.
Great to be with you. And I will share. I will share YouTube. I will share the recordings from YouTube shortly.
Right.
Thank you very much, Natarajan. Have a great day.
Thank you, doctor.
Thank you. Thank you so much.
Our day is still
Thank you,
starting
sir.
here, but
Thank you, everyone.
Have a nice day.
Have a nice day. Bye-bye.
Obrigado to
Bye,
Brazil.
sir.
Obrigado. How do I say obrigado in your language?
Dhanyawad.
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 Okay.